Okay, what use does knowledge? Okay, what use does knowledge of the cardiac effects of potassium have for surgical practice? Potassium-rich cardioplegic solution are used to arrest the heart in diastole to permit cardiac surgery once. Okay, so these two questions are related. In the previous video, we have to stop the video, but listen. So this question and this question are related. So use of this mechanism is in surgery. So if you have this cardiac cell, okay, this is your cardiac cell, and if you put it in potassium solution, so what will happen that this will cause a cardioplegic situation. So potassium rich cardioplegic solution are used to arrest the heart in diastole to permit cardiac surgery once cardiopulmonary bypass has been established. Okay, so what happens actually, we have normally potassiums or cells or bags of potassium, you should know, in the sea. So you know that in the sea, normally in the sea we have sodium. Sea water is salty, so potassiums or cells or bags of potassium in sea. So what happens that these are potassium bags. So we have potassium here, okay, and outside is sodium. This is the normal situation. But when there is a hyperkalemia, so we have potassium here. So normally we have plus charge on the outside and negative charge on the inside. But when there is hyperkalemia, we have less positive on the outside as well, less positive. Okay, so the concentration gradient is decreased, the negative and positive, outside positive, inside negative. So when there is hyperkalemia, so the concentration gradient is disturbed, and so the depolarization mechanism is disturbed, and so that's why the cardiac cells are normally we have, let's suppose, normally we have this level of action potential. For example, if the cell electrochemical gradient reach this level, then there will be action potential. So what happens when there is hyperkalemia? So this potential is increased, this is increased. So normally cells get to this point to contract, but in hyperkalemia they have to get to this point to contract. So that's why the potassium rich solutions can cause cardioplegia. And so the same mechanism is here. What is the action of potassium on cardiac muscles? Mechanism: excess potassium causes the heart to dilate, flex and decrease the heart rate, and can block the conduction of the cardiac impulses. High potassium depolarizes the resting membrane potential, causing it to be less negative, which will decrease the intensity of action potential, making the contraction weaker. Okay, so manifestations of hypokalemia: muscular weakness and cramps, and lethargy and confusion, and atrial and ventricular arrhythmias, paralytic ileus. Hypokalemia. And what are the manifestations of hyperkalemia? So in hyperkalemia there will be muscle cramps, there will be contractile muscle weakness and flexor paralysis, anorexia, nausea, vomiting, diarrhea, hyperactive bowel sounds, abdominal. So in hypokalemia there will be paralysis, and in hyperkalemia there will be hyperactive bowel sounds or like diarrhea. In hypokalemia there will be constipation. So Wieden-Curious complex, okay, and peak T waves, we have peak T waves and Wieden-Curious complex, peak T waves, dysrhythmia, hypotension, sudden death. What are the ECG changes in hyper and hypokalemia? So ECG changes in hypokalemia: slightly peak P waves, these P waves, these will be peaked. Prolonged PR interval, we will have prolonged PR interval, ST depression, shallow T waves, and U waves, prominent U waves. So if you push here, depress the T waves or ST depression, so there will be pull effect on the P wave, and if you pull here, there will be push on it or loss of P wave. So flat or absent P wave, prolonged PR interval. Okay, so prolonged PR interval in same occurs in both because there will be low heart rate. Decrease R amplitude, widen QRS, decrease R amplitude and widen QRS, ST depression same, and tall peaked T waves, tall peaked T waves. So this is same, prolonged PR interval, ST depression, widen QRS, widen QRS. What is the emergency management of a hyperkalemia? So emergency, I will immediately follow the CCREST protocol, implement continuous cardiac monitoring. This is very important. Always do cardiac monitoring. Stop all potassium containing intravenous fluids including Hartmann, calcium gluconate to stabilize the heart membrane, 10 ml of 10% in 10 minutes, given over 10 minutes, which provides short-term cardioprotective but does not decrease the serum potassium. It just stabilizes the membrane. Measure to reduce serum potassium. So insulin 5 to 10 units in 50 ml of 50% decrease IV over 30 minutes, which increases the cellular uptake of potassium. So we know that insulin can cause reuptake. So sodium bicarbonate 50 millimole IV over 5 to 10 minutes followed by IV infusion of 1.26 to 1.4% at 100 ml per hour. Salbutamol 5 to 10 gram per minute by intravenous infusion or nebulization. Loop diuretic furosemide 40 to 80 milligram. Usually one ampule is 20 milligrams, so you should give 2 or 3 or 4 ampules IV. Calcium arsenium 15 gram per oral or 30 gram per rectal. Okay, so can be given to provide, you can remember this, that oral is better than rectum, so you have to increase the dose. Can be given to provide long-term potassium depletion. These are resins, these sequester the potassium. Last measure is hemodialysis. So if potassium is equal to or greater than 6 millimole per liter, so we go for hemodialysis. Okay, or pH or if there is severe acidosis like pH is less than 7.20, so go for hemodialysis. What are the indication of hyperkalemia, AKI? So okay, so this is actually, the question is misworded. These are the indication of a hemodialysis or renal therapy, alternative renal therapy. So AEIOU. So A is your acidosis less than 7.10 or 7.20, electrolytes, refractory hyperkalemia or greater than 6 millimole per liter, intoxication, toxic alcohol, salicylate, ethylene glycol, lithium poisoning, fluor overload in congestive heart failure, uremia, uremic pericarditis, uremic encephalopathy. So you go for renal alternative renal therapy or hemodialysis. Ethical issue of dialysis of 77-year-old man with dementia. So in dementia, they are unable to give you consent. So what will you do? The patient will be unable to give consent. So I will proceed for dialysis for the patient best interest with 2 consultant signatures. This is very important, with 2 consultant signatures. Also, I have to involve the staff of his residentiary house, special nurse, or if the patient is in the care home or residentiary house, so I will involve their staff or their special nurse. Okay, so post-operative day 4, anterior resection, BP 80/50, the patient underwent anterior resection and now BP is low, respiratory rate is high, heart rate is 110, temperature 38, urine output 450 ml in the last 24 hours. So this is also AKI picture. So what is your diagnosis? Considering hypotension, tachycardia for the with fever post-operatively suggests septic shock, most probably due to anastomotic leak. What are your differential? Anastomotic leak, peritonitis, perforation, pelvic abscess. What is Q-SOFA? AD2 of systolic blood pressure less than 100, respiratory greater than 22, and GCS greater than less than 15. This is your Q-SOFA. What could be the cause of decreased urine output in these patients? Prerenal hypovolemia, hemorrhage, or renal can be drug-induced post-renal obstructive uropathy. Maybe he is BPH. So this was all about the hyperkalemia and renal impairment. So the tricky thing in this station is the management of the potassium hyperkalemia and the effects of hyperkalemia on heart muscle or oral muscle cell, or in general hyperkalemia effects on cells. So you have to be very because they ask these tricky questions. Now we can repeat this. So I think it's not important that you remember the doses, but if you remember it, it's very better, or like it will be a plus point. But you should remember that insulin can push 5 to 10 units in 50 ml of 50% dextrose IV or 30 minutes. So take the 50% dextrose, okay, 50 ml, and put 5 to 10 units in this and give him over 30 minutes, okay. And then sodium bicarbonate 50 millimole IV or 5 to 10 minutes, followed by IV infusion of 1.26% to 1.4% solution and 100 ml per hour. Salbutamol you can give 5 to 10 gram per minute by intravenous infusion or nebulization. Loop diuretics 40 to 80 milligram. Calcium 50 gram per oral, and per rectal you can give him 30 gram. So yes, and hemodialysis when it's greater than or equal to 6 or 6.5, and when there is severe acidosis like 7.20, less than 7.20 or 7.10. So these are the indications for this renal therapy, renal replacement therapy. So renal replacement therapy is AEIOU acidosis, electrolytes, refractory intoxication, and fluid overload and uremia.